Hello, and thank you for joining us for the 6th Annual Global Summit on Kidney Disease Innovations, Vox Populi. The time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from the George Washington University School of Medicine and Health Sciences. My name is Carl Juresic, and I'm a kidney transplant patient and an AAKP International Ambassador from Australia. I've had chronic kidney disease for over 23 years. As a teenager, I was diagnosed with ANCA vasculitis, and unfortunately, it affected my kidneys. 10 years later, I needed a kidney transplant, which my dad generously donated. And 13 years later, lucky enough, I still have that transplant today. In my professional life, I've always worked in strategy and consulting. For the last 15 years, I've worked at companies such as PricewaterhouseCoopers, Accenture, Facebook, and I'm currently leading Uber ads across the APAC region from a strategy and insight perspective. I'm also the founder of Kidney Ally, a health tech company dedicated to empowering patients to slow down the progression of kidney disease. AAKP is incredibly important to me. It connects me with a community that is so integral to my everyday life. And since joining as an ambassador 4 years ago, I've had so many opportunities to empower patients on their journey, and I love how the community fosters this connection. This year's Global Summit theme, Vox Populi, was purposely and strategically chosen by the AAKP for its historical meaning, voice of the people. I am one of the people they have chosen to raise their voice in support of greater care decisions and innovation around kidney care. And I am one of the voices demanding change in the status quo of kidney medicine. Over 850 million individuals in the world have some form of kidney disease, and this number is increasing every year by 5 to 7%. And every year we lose thousands of innocent lives to preventable kidney issues due to the lack of timely access to treatment. AAKP believes kidney disease is both a workforce and a healthcare issue. The disease takes a devastating toll on human life and livelihoods. Most people understand that kidney disease left undetected and untreated can lead to premature death. However, most are unaware of the way it impacts a person's dignity and the ability to provide for themselves and their families. Kidney diseases and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years as the decade of the kidney. The time is now for kidney patients, consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic we can save more lives. But to do this, we must demand new screening guidelines, diagnostics, new biologics, and new devices. Together, we can manage and solve this growing public health crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely access to care. If governments fail to do this, we must raise our voices and demand an end to negative government determinants of health. Make no mistake, every nation is impacted by kidney disease and millions of people are at risk. The optimistic news is that every person watching this today can help those impacted by kidney disease and make an impact within their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in common purpose larger than any one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the people, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I am honored to serve as the moderator for our session entitled Identifying a Core Cancer Outcome for Kidney Transplant Trials. It is a great pleasure that we introduce our next speaker, Dr. Christopher Blosser. Dr. Blosser is a transplant nephrologist and a professor of medicine at the University of Washington, Fred Hutch Cancer Center, and the Seattle Children's Hospital, caring for people before and after transplant. His research is focused on understanding the risks and responses to cancer treatments and improving the clinical care for people with cancer before and after organ transplant. In response to the significant risks and outcomes in this population, he established a patient-centered research center, the Center for Innovation in Cancer and Transplant, including a national bioregistry and an integrated cancer and organ transplant clinic at Fred Hutch Cancer Center. We've had the honor of having Dr. Blusser's participation in many AAKP events and webinars over the years, and we are extremely pleased to have him join us for the Global Summit. Dr. Blosser, I hand the presentation over to you.
Thank you so much, Carl, AAKP, and George Washington University for inviting me to this year's Global Summit. I really appreciate the invitation. And today, my hope is to talk with you for a little while about cancer before and after kidney transplant. Just to cover, I have no disclosures that are relevant to this conversation. I hope we can define the incidence, mortality, and risks of cancer before and after kidney transplant. We will discuss waiting times for kidney transplant after cancer. And also, I hope that you will come to understand the concepts and applications of cancer immunotherapy related to situations before and after transplant. So many people are waiting for a kidney transplant. This week, that list includes over 89,000. And thankfully, we continue to provide more kidney transplants over time. Last year, over 27,000 people received a kidney transplant, and right now, over 430,000 people live with a functioning kidney allograft. There are some other good news. The cancer mortality rates have also improved over the last 30 years for the most common cancers, including breast, colorectal, lung, and a lot of that has to do with public health measures. As more people are able to live longer, they are living with more chronic conditions, and those chronic conditions do lead to an increased risk and development of cancer. So there's more cancer and organ failure in the general population. There's also more cancer in the chronic kidney disease and end-stage kidney disease population, partly because more people are living better despite cancer and despite organ failure. That results in more people coming to need a kidney transplant and living with a kidney transplant and having higher risk of cancer in those situations. As of right now, about 10% of kidney transplant recipients have a history of a pre-transplant malignancy. The most common cancers that can develop in the setting of kidney disease, including those living on dialysis, are kidney cancer, bladder and prostate cancer, multiple myeloma, and amyloidosis, which are conditions of proteins produced by small immune cells called plasma cells. Liver cancer and other skin cancers are also relatively common, along with cervical and Kaposi sarcoma. The most common cancers develop at an increasing rate with progressive kidney disease, so that about 5 years before starting dialysis, people in Australia have a 16% higher risk of cancer compared with the general population. Those on dialysis have about a 35% higher risk, and after transplant, it's markedly higher, around 327% higher, and we will talk more about after transplant later. Cancers develop at a higher rate in the setting of kidney failure, including on dialysis. Based on this information from Australia, people 5 years before dialysis are about 16% higher risk of cancer. Those on dialysis are 35% higher risk, and after transplant, up to 327% higher risk. We'll talk more about after transplant risks later. The risk of death from cancer in the setting of dialysis is around 2.6-fold compared with the general population in Australia. And the most common cancers to cause death in the setting of dialysis are multiple myeloma, testicular cancer, and kidney cancer. There are multiple risks that we currently know cause cancer before a transplant, including on dialysis. We know that age, chronic conditions like type 2 diabetes and dialysis needs, tobacco use, and obesity all lead to a higher risk of cancer. The more someone is on dialysis, the longer they are on, the greater that risk is. That risk is slowly rising over that time, and that's because all of those conditions decrease the ability for the immune system to do its normal surveillance, looking for cancer cells and killing those cells. There's also less ability for the DNA in our cells to be repaired, and that can lead to mutations that then cause cancer. And separately, oncogenic viruses like hepatitis B or C, Epstein-Barr virus, and human papillomavirus can all cause different kinds of cancers. The U.S. Preventative Task Force has recommended cancer screening for most patients, most people in the country according to their age, and that includes for colorectal, breast, cervical, and lung, as you see here. In people on dialysis, cancer screening is not necessarily recommended. We need to individualize our cancer screening in the setting of kidney disease and end-stage kidney disease, depending on the situation, in part because kidney failure itself is a risk of death for other reasons. There's currently a lack of evidence that cancer screening improves survival in that situation. And when people don't have screening and are later diagnosed with a cancer, they are often diagnosed at a later or higher stage cancer, which makes it more complicated. Kidney disease and dialysis, of course, further complicate surgery and chemotherapy choices. And so, in result of that, the American Society of Nephrology and the American Board of Internal Medicine have advised that cancer screening not be done for people living on dialysis unless they are transplant candidate. Thankfully, there's more updated information that has come out related to the possibility of getting a transplant even after surviving cancer. And that's mostly because people are living better and longer and recovering fully from cancers that previously they could not. And as we have better treatments and better understanding of the response to those treatments, the waiting time from achieving a response to the cancer, the waiting time from that treatment to transplant has been refined, sometimes shorter, other times longer, depending on the cancer type and the stage of the cancer. And so more recently, a group of experts have published a number of publications that you'll find in the American Journal of Transplantation and the other journal, Transplantation, with recommendations of how long to wait from cancer to transplant, including breast, prostate, lung, and colorectal cancer, as you see here. As well, melanoma and kidney cancer are common and need to be addressed before someone may be a candidate for a transplant. So overall, kidney disease leads people to have about a 1.3-fold higher risk of cancer compared with the general population. The most common cancers are bladder, kidney, and skin cancers. And we know that kidney cancer screening and other cancer screening needs to be individualized, but based on general population guidelines. The waiting times to guide evaluation and possible transplant is based on the cancer type and stage and the response to treatment. And there are possibilities of using immunotherapies, which we'll discuss more in a minute. Using immunotherapies activates the immune system to attack a cancer, and that may be very effective in this situation. Right now, the data is limited. I surely support partnering with oncologists and palliative care members to really address the best overall goals of life. Overall, I would suggest that personalized medicine is the way we should approach all of life, including in the setting of cancer before or after a transplant, using cancer type and stage as information along with biomarkers that we have available. But in addition to that, being aware of the current treatment options, the off-target effects, other chronic conditions that influence and inform decisions, and finally, and most importantly, focusing on a person's health and life goals to guide those decisions. Now we will think about cancer after kidney and organ transplant. We know that cancer is a higher risk situation after transplant, and people who have received an organ transplant are 2 to 4 times higher risk than the general population. The cumulative incidence of a cancer 15 years after transplant is 10 to 15%. That means that people are at about a 10 to 15% chance of developing cancer in 15 years after their transplant. The most common cancers to develop are skin cancers like squamous cell, basal cell, along with non-Hodgkin lymphoma, kidney cancer, and anal cancer. You'll notice that the more common cancers in the general population are less common after kidney transplant, such as lung, colorectal, breast, and prostate. Those cancers are also higher risk and more likely with kidney transplant than in the general population, and yet the cancers that are standing out the highest are those that are more responsive to the immune system, such as skin cancer and lymphoma, kidney cancer, and melanoma. Our transplant immunosuppression has been very effective in preventing rejection, and many of these drugs have been around for 15 to even 30 years, such as cyclosporin, tacrolimus, basiliximab, belatacept. All of these medicines are intended to suppress the activity of cells in the immune system, and the most common cell that we choose to suppress are called T cells. Those T cells govern an overall immune response against a kidney transplant or against a cancer. When we add immunosuppression, multiple things change. The immune system has fewer cells that are made and don't function as well, and so there is less tumor surveillance. Those cells also are not as active and cannot respond as aggressively when the immune cells identify a cancer. And finally, there's more cells that regulate a response, meaning they put the brakes on the tumor response, all leading to a lesser tumor surveillance and anti-tumor response, allowing cancer to grow to a greater extent. Skin cancer is the most common cancer after transplant. Kidney transplant recipients are 10 to 20-fold higher risk of skin cancer compared with the general population. And the most common cancer is squamous cell carcinoma, or SCC. Like you see here on the right, SCC is a common cancer that develops on the surface of the skin. Sometimes it is red around the edge, can be variable in terms of its bumpiness or color. So if you ever see changes in your skin that don't look right and don't resolve within a few weeks, I would strongly suggest that you have that evaluated. Certain immunosuppression medicines increase that risk, including azathioprine, which is a very old medicine. And overall immunosuppression, when it's given or taken every day for years, does increase the risk of skin cancer. On the flip side, sirolimus is a different immunosuppression medicine that can decrease the risk of skin cancers, especially squamous cell and basal cell. But there's nothing like protection, including sun protection with sunscreen, hat, and sleeves to prevent skin cancers over time. I strongly recommend that everybody after a transplant see a dermatologist for a skin evaluation every year. Certain cancers are more likely to cause death after a kidney transplant, and cancer overall is the second leading cause of death behind cardiovascular disease. Lymphoma, kidney cancer, and melanoma are the three most likely to cause cancer death. There are some new treatments available and have been available for the last 15 years or so that have really changed the options of treating cancer, especially cancers that are advanced. Cancer immunotherapy intentionally uses medicine to wake up immune cells to attack a cancer. The most common are called immune checkpoint inhibitors, such as PD-1 or PD-L1 checkpoint inhibitors. And what those do is alter the way a T cell is interacting with a tumor cell, leading to it being activated and sending out other signals to attack that tumor. Other treatment options that also can be used to treat a tumor with immunotherapy include antibodies and or CAR T cell therapies. We'll talk about that more later. Unfortunately, when we activate the immune system with immune checkpoint inhibitors, there are certain risks, including that we're activating the exact cells that we're trying to suppress in a transplant situation. So the risk of rejection is that much higher. And in this multi-center study that I supported Dr. Murakami in doing, we realized that about 42% of people who were treated for cancer with an immune checkpoint inhibitor experienced rejection, and they experienced it within 1 month of starting the treatment. Of those who did have a rejection, 65% lost their graft and needed to return to dialysis. While that is sobering, there was some very positive response rates, specifically for people who had squamous cell carcinoma or melanoma, similar to the general population of 36 to 40% response rates. So we have some difficult choices to make when cancer occurs in the setting of transplant. And thankfully, there's some new treatments available that I mentioned, like the immune checkpoint inhibitors, along with CAR T-cell therapy. Chimeric antigen receptor T-cell therapy, or CAR-Ts, are a new treatment that is currently being used to treat lymphoma or myeloma, which are blood cancers. The way this works is that people provide a blood sample that allows the laboratory to specifically select the T cells from that blood and insert a gene into those T cells that are specific for the protein sitting on the tumor. Once that gene is inserted into the T cells, they are grown to be many millions of T cells of the same type. And then the recipient who has the cancer is given a number of chemotherapy drugs to suppress their immune system before being infused with those chimeric antigen T cells. Those T cells are the same genetics as the person, but with that additional chimeric antigen receptor that attacks the tumor. That has been very effective in treating people who have lymphoma and myeloma in the general population. And we're just now learning how to use it in the setting of transplant. I helped to lead this analysis of the people who have been treated for lymphoma and myeloma with CAR T therapies. And what we learned is that it is as effective in transplant recipients as in the general population, with an overall response rate of around 82% and the complete response rate of almost 60%, which is very favorable. The main limitations in the transplant situation are the cost, which are the same for the general population, and the duration of response is limited, meaning that the length of time that these cells live and control the lymphoma is shorter, approximately 6.5 months. And that's likely because we need to continue some immunosuppression to prevent rejection in the setting of the lymphoma or myeloma. We have much more that we can learn. And part of that learning comes by caring for people who are experiencing cancer before and after transplant. I started the first of its kind multidisciplinary consult clinic at the Fred Hutch Cancer Center and University of Washington to care for people who have challenges related to transplant and cancer combined. The most common questions that we address are when to proceed with an organ transplant in the setting of a cancer. What are the optimal cancer treatments to help someone get to that transplant? And if someone develops cancer after a transplant, what are the optimal treatments to help that person thrive, including keeping their organ transplant alive if at all possible? Yet there are many questions still to answer and much to understand in order to help people live better lives. So I also lead the Center for Innovations in Cancer and Transplant, which is a research center here at the University of Washington and the Fred Hutch. And we lead a national bioregistry, a patient-level registry of solid organ transplant recipients and candidates, including people who have had cancer, to better understand their experience. And that registry is available for other investigators and clinicians around the world to work with us to better study patient-reported outcomes, data-driven epidemiology research, and translational research. So for people who have cancer in the setting of a transplant, we know that transplant recipients are 2 to 4 times higher risk for cancer, that skin cancer is the highest risk, 10 to 20-fold higher risk than the general population, and that cancer is the second leading cause of death. General cancer screening guidelines remain the recommendation post-transplant, And we may be able to use immunotherapies like immune checkpoint inhibitors, but need to be very aware and prepared for the possibility of a rejection, which can happen 35 to 50% of the time and within 1 month of starting treatments. CAR T therapies are short-term effective therapies that may help someone survive longer and better, and yet there's much more for us to learn and to be able to apply for better life in the future. So again, personalized medicine includes all of the factors that we discussed before, and fundamentally addressing a patient's health and life goals will help us address these bigger questions for every single person that we live with. So I want to thank everybody's attention and attendance for this webinar. If you have any questions or would like to reach me, feel free to do that by my email address. My patients and the providers I work with, the nurses I work with, I really appreciate everybody who I get the chance to work with and work to really improve lives one day at a time. Thank you also to Carl and AAKP. And at this point, I'll take any questions.
Thank you, Dr. Blosser, for that insightful presentation on the risks and responses to cancer treatments and improving the clinical care for people with cancer before and after organ transplant. However, before I let you go, I've just got a few questions I'd like to ask you. AAKP and our allies have been excited to see the work you are doing in the USA at the University of Washington to address the unmet needs of kidney patients dealing with cancer concerns and cancer diagnosis. Can you tell us how the voices and insights of patients are helping you grow the center to address its needs?
That's a great question. I think that it's really important that we continue to not only include, but put our patients at the forefront of this process. And because of that, we have a community engagement committee led specifically by patients to guide us in the research questions we ask, the approaches to any process that relates to our research, and by doing so, giving us grounding, clear understanding of what is important to patients. It also gives us a chance to share our findings more quickly with people who are living with it, whatever that cancer condition is, and to ask for them to put words out into the community that make sense to them and reflect what we're finding.
Given the concerns that so many transplant patients have about cancer issues, can you tell us what news research is underway in the nexus kind of between transplant and cancer, and if there's a greater opportunity for patient participation in research and perhaps clinical trials?
Those are all really important areas to address. And the answer is there's a lot of exciting growth in this field. One area that I think is really important is that we are studying how the social determinants of health, the lived environment of community and insurance, education, and the opportunities to engage safely and in a supportive environment with healthcare, how those factors impact someone's life with cancer and or with a transplant. So we have continued to enroll patients in a prospective study of their social determinants of health as they come forward for a transplant here and or they receive cancer treatment here. In addition to that, I'm excited to continue to work with a number of collaborators from other parts of the country, including Allison Hart and Eric Engels, where we, in the next months, will be starting a project to study the risk of cancer in the setting of dialysis and using data to guide how long patients will likely need to wait before getting a transplant. So far, that waiting time is based mostly on expert opinion. There is definitely opportunity for us to look into clinical trials in the future, knowing that cancer is infrequent enough in one specific center that we definitely need to partner across different cancer and transplant programs to address these questions together. And that includes patients raising questions and specific concerns about what cancers and what treatments we should be testing.
We know there's been an international effort through the Transplant Therapeutics Consortium to request FDA approval for a new clinical endpoint to aid development of the next generation of transplant drugs. However, do you think that the future of transplant drug development can be informed by your work and research, and perhaps we could see new immunosuppressive drugs that reduce cancer risks?
Thank you for that excellent question. And I am excited about how the consortium is guiding future opportunities for treatments that have diminished risk of cancer and other serious side effects. As we study the currently available treatments, we are better understanding not only what those effects are for those drugs, but what the immune system is doing behind the scenes. And by better understanding the underlying mechanisms, the way drugs work, we can define and then design better effective drugs that are less risk for patients in the future. That includes medications that may be able to prevent rejection with less side effect, or treat cancer with less side effect, or potentially both, depending on the ability to harness the immune system more accurately. All of those elements are part of what I'm wanting to study and continue to study here with CICT. Thank you.
So in 2019, AAKP declared the next 10 years the decade of the kidney, in order to build that international support for innovation and better health outcomes for patients. However, thinking about the last 10 years and the next 10 years, should transplant patients with cancer feel optimistic about the future? And how can patients and advocates kind of work to support your efforts at the University of Washington?
Thank you. Yes, I think all of us can and should feel optimistic. Not only people who are kidney transplant recipients now, but also those who are living on dialysis, waiting for a transplant, because we are better understanding and applying that information to achieve better lives now, shorter waiting times to transplant, and better lives after transplant. This work is not something that I can do alone. It requires many of us to partner as teams, and we need the resources and committed people to do that. I would welcome everybody who's interested to reach out to me through the email on the slides. If one is interested in collaborating, in participating in research, in financially supporting the work we're doing, we have a lot to do. I'm certain we can do it together, and with that, achieve much better lives for many, many people in the future.
As always, thank you, Dr. Blosser.